MVW Nutritionals is really happy to introduce a series of YouTube videos entitled New CF. And this first in a series is going to highlight, and that's probably the key phrase, highlight how the advent of CFTR modulator therapy has influenced the management of cystic fibrosis. And we'll specifically focus on fat-soluble vitamin management. So as we go through this, we're going to look at new data. We're going to look at the first prospective study published in JPGN in mid-2025 entitled The Effect of Cystic Fibrosis Modulator Therapies on Serum Levels of Fat-Soluble Vitamins. And more recently, 2026, a new consensus recommendation that really directs caregivers to consider the formulations that they're using. This was published in the Journal of Cystic Fibrosis in February 2026. We'll look at new approaches, and we're going to sort of go back and looked at what clinicians did in the absence of this new data and these new recommendations. And then finally touch on new possibilities. So before looking at the new data, I think it's important to look at some of the early studies surrounding the effects of CFT modulators on serum fat vitamin levels. And note that the findings were inconsistent. Well, why? Well, one, the data was retrospective. The results were likely confounded due to differing protocol designs. Different study durations. Time to the first serum draw to measure fat-soluble vitamin levels after initiating CFTR modulator therapy. Seasonality. We know the effect of seasonality on vitamin D levels. And other patient exclusion-inclusion criteria. And while the data suggested a directional influence on fat-soluble vitamin levels, study-to-study findings were inconsistent. So the new data, published in JPGM reports, entitled The Effects of Cystic Fibrosis Modulator Therapies on Serum Levels of Fat-Soluble Vitamins. It was the first prospective study, multi-center, 224 patients. It analyzed the effect of modulators, that is CFTR modulators, on dual and triple therapy. Patients were assessed after initiating a modulator, immediately after initiating a modulator, and then at 6 and 12 months. So what did the authors find? What were the results? Well, first, ETI produced a significant change in vitamin A and D levels within the initial 6 months on the study. And these changes were maintained through the end of the study protocol at 12 months. The results with dual therapy were different, and not surprisingly, because we know that triple therapy has a more pronounced effect at restoring CFTR function. But with dual therapy, they only noted an increase in vitamin A levels, so vitamin A, not D, within the first 6 months. And these changes were not sustained at 12 months. And then finally, no differences were found within either group, dual therapy or triple therapy, with respect to vitamin E. Let's now touch on the new consensus recommendation, the recommendation that came out in 2026. It was published in the Journal of Cystic Fibrosis, February of this year, and was based on a comprehensive review of the data that exists. And what the collective group found was that vitamin A levels may increase significantly in children receiving ETEI or Trikafta, with some evidence suggesting elevated risk of hypervitaminosis. I think the challenge is that, when initiating a CFTR modulator, how can one decide, well, who are those that will be affected and those that won't be? And of those affected, to what extent? They concluded that vitamin D levels in children receiving ETI were inconsistent. And most studies did not adequately consider the effect of seasonality, which we know is a key factor. And then finally, vitamin E levels did not appear to change significantly in children receiving ETI. So while the consensus recommendation is far broader than multivitamin supplementation, it does speak to vitamin A. And the clear recommendation is to use for clinicians to consider using formulations that are predominantly pro-vitamin A or beta-carotene in content. And measure vitamin A serum levels before initiating CFTR modulator therapy or changing therapy, and then within several months post initiation. Let's now touch on approaches and products, because before the most recent prospective study, and the only prospective study that I'm aware of, and the new recommendations, caregivers were really forced to rely on their experience and an empiric approach. And we heard several different approaches to managing elevated vitamin A levels from centers across the country. I mean, one was simply reduce the serving size to go from 2 soft gels or 2 chewable tablets to 1 with a CF specific product. And while this was effective in reducing the preformed vitamin A, it also reduced the D, the E, and the K to what was almost always less than the CFF recommended guidelines that originally came out. Some suggested just switch to an OTC, and the patient would go to a pharmacy and make their selection. But here laid some risks, because there was the potential for unintended consequences. Because if one looks at the label of many or most OTC multivitamins, the vitamin A content is predominantly preformed vitamin A. So rather than reducing preformed vitamin A, switching to an OTC can actually increase preformed vitamin A. And at the same time, the D, the E, and the K input or intake is lower than the original CFF guidelines. We heard some say, well, we just tell our patients to stop taking multivitamin supplementation. But there is one additional consideration, and that's a product specifically formulated with the understanding of the potential effects of CFT modulators on fat-soluble vitamin levels. And that's the MVW modulator formulation multivitamin supplement. In its development, we focused on really 2 things. One, which we now know is consistent with the new recommendations, is a very high percentage of vitamin A as beta-carotene. 96.5% of the vitamin A is provided as beta-carotene, pro-vitamin A, with just 3.5% as preformed vitamin A. And this ratio was really driven by our trying to keep preformed vitamin A at about 50% of the recommended daily allowance, the RDA, realizing it's a supplement. Acknowledging that beta-carotene is only converted to an active form as needed by the body. And I'll add, FDA has not set an upper limit for beta-carotene because of the perceived safety of beta-carotene as a form. Several pharmacists, though, early on drew to our attention that, yeah, but total vitamin A is higher in the modulator formulation than the legacy or the traditional CF-specific multivitamins. And the answer is yes. But again, let me add, predominantly as beta-carotene. Again, 96.5% of the total vitamin A is as provitamin A or beta-carotene. But we recognize that there is a genetic variation. A genetic variation in the BCMO1 gene. And if you look at the third sub-bullet, this is not something that occurs infrequently. This exists in the general population in maybe as much as half of everyone. And with this genetic variation, you poorly convert beta-carotene to an active form, and hence the name poor converters. If you have substitution on both alleles, you can have a 70% reduction in conversion efficiency of beta-carotene to the active form. With the variation just on one allele, 29%. So the higher total A, again, as a provitamin A form, beta-carotene, is to accommodate those people who have this BCMO1 genetic variation. This first in the series of YouTube videos is really intended just to highlight the most current information, both the data from studies and the new guidelines, and to help build perhaps a new foundation from which to consider the use of multivitamin supplementation for those individuals on CFTR modulators. And we know that modulators have created a new CF and new possibilities for both patients and families, but also acknowledge that for some, they've introduced a new challenge as it relates to fat-soluble serum vitamin levels, and particularly vitamin A. There's a new possibility in terms of product, though, because the modulator formulation, and we hear this phrase a lot, personalized medicine. The MVW modulator formulation offers a personalized vitamin A dosing based on the fact that it's predominantly beta-carotene. 96.5% of the vitamin A content is as provitamin A or beta-carotene, with just 3.5% as preformed, while offering D, E, and K content that's aligned with traditional CFF guidelines. So there are new possibilities. And MVW and me personally would encourage you, as we develop the subsequent YouTube videos, which will delve more into the data, the new prospective study. It'll get more into how the recommendations were formed for vitamin supplementation, and particularly vitamin A. I would encourage you to, give us feedback. All this information will be on our website, but give us feedback. Provide your comments. Tell us what other information might be interesting for us to include, because we do recognize that today that few centers are able financially, due to budget constraints, to have all of the caregivers attend either the North American CF meeting, the different symposia, the different educational meetings. That information is often brought back. But we want to provide another conduit to, let's say, catalyze discussion because of the number of new people in the space, and importantly, because we really are dealing with what I'll candidly term a new CF.